Hello everyone, and welcome to my scholarly project presentation on improving health literacy effects on compliance to pain management. Committee members for this project included Chairperson Dr. Carol Berger, Dr. Rita Wunderlich, Dr. Lisa Struer, Dr. Parker Bell. To understand this study, we first need to understand some concepts and terms. So, to begin, what is health literacy? The CDC defines health literacy as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Basically, can you understand your treatment plan? What is pain management? This is management of chronic or acute pain through various methods and interventions, though the most common intervention is opioid management. We must also understand what compliance is. The Oxford Dictionary defines compliance as the action or fact of complying with a wish or command. What we are looking for in this study is patient compliance to treatment plans set forth by their healthcare providers. We also need to understand why this is important. For the clinic in which this study was done, dismissals were really skyrocketing due to noncompliance. Collectively, we came together to decide, what can we do? What can we do to make a difference, retain patients, improve patient outcomes, and grow our practice? Pain is one of the biggest reasons that people seek medical attention, and opioids continue to be the most prominent treatment offered to these patients. Over the years, this has led to an opioid epidemic that has been and continues to be a costly burden on the United States healthcare system. Patient compliance with opioid treatment plans for chronic pain control, or lack thereof, is one factor that can lead to poor patient outcomes, further burdening that already strained system. Health literacy related to treatment plans, especially for chronic opioid therapy, is paramount to the success of the treatment plan, since understanding expectations can increase compliance. When reviewing what could be done to improve patient outcomes through better compliance, it was recognized that the current pain management contract was written on a college reading level. The standard reading level in the United States is 6th grade. It was decided to lower the reading level of the pain management contract to see if it would make a positive difference in patients, which leads us to the research question: does the implementation of a pain management contract written at a literacy level appropriate for patients enrolled in a pain management clinic improve compliance with the contract and decrease dismissal rates as opposed to the standardized contract written at a college level? The teach-back method was also used with verbal review. For the literature review of this project, several themes were identified common threads connecting each. The major themes that were identified for this project were opioid misuse, literacy, and compliance. 12 articles were selected initially for review, looking for support and guidance in determining if increasing health literacy can increase compliance with chronic opioid treatment plans. Opioid misuse was the first major theme that was identified in the research. It is important to understand that opioid misuse usually starts as a legitimate need for pain control, but as the pain becomes less well managed, as tolerance occurs and whatnot, it can morph into abuse. So it is a disease that has consistently contributed to the opioid epidemic and is a costly burden on the healthcare systems. It was around $1 trillion annually in the United States in 2021, and I'm sure that number has gone up since this time. This is not only associated with overdose treatment, but achieving and maintaining remission. The opioid burden in 2022 was for the whole entire United States was found to be around $1.5 trillion and greatly affected those of lower socioeconomic statuses. Assessing patient compliance with treatment plans can be the first indicator of possible opioid misuse. It could help initiate preventative measures, but differentiating between decreased pain control due to the body's natural responses and drug-seeking behavior can be difficult to pinpoint. Literacy was the next major theme identified in the research. Literacy can lead to poor patient outcomes when related to health care, and this can have an even more devastating effect on those of lower socioeconomic status due to lack of access to health care in general, but also a lack of understanding of any prescribed treatment plans. Lack of education probably contributes to this as well. Still, an introduction of ways to factor in patients' literacy levels when initiating a plan of care can lead to better patient understanding and therefore better patient outcomes, as this helps employees shared decision making through literacy appropriate interventions. Literacy must be considered when initiating any treatment plan for a patient, but it is essential to those in chronic opioid treatment because they have to understand exactly what is required of them in order to stay compliant. The last major theme identified in the literature review for research was compliance. Again, that is the act of complying to demands. It is necessary for any patient care, and it's measured in different ways. In the pain management world, it is measured through drug screens and pill counts. Lack of patient compliance with treatment plans can have negative patient outcomes, but lack of comprehension due to low or limited literacy can greatly influence compliance with any treatment regimen. Ensuring the patient is supported through multiple disciplines required to treat any condition requiring medication management is a multidisciplinary affair. It requires cooperation across all disciplines and employs shared decision making with the patient. When we speak of across all disciplines, we will remember that a patient will choose a healthcare provider to prescribe medications, but must also employ a pharmacist to fill that prescription. And if chronic pain is one of the main reasons that people seek medical treatment, and chronic opioids are still the most used intervention Adherence to an opioid treatment plan is necessary for success. Compliance can begin to wane when pain relief from prescribed treatment plans begin to wane, and patient can seek other methods of pain relief. Noncompliance with these treatment plans can lead to dismissal from pain management practices, leading to poor patient outcomes like overdose. And noncompliance can again come in many forms, but specifically for the pain management industry is usually measured in drug screens and pill counts. So, if we are looking at the importance of literacy and compliance, why is pain control important? We've already discussed that pain is still the number one reason that people seek medical attention, and opioids continue to be the number one intervention prescribed. This can lead to dependence. This is why there is a need for chronic pain management with opioid therapy, and compliance is necessary to continue these treatments. Compliance is measured through urine drug screens or oral drug screens or blood drug screens of some sort, and pill counts for the pain management industry. Literacy has to play a part in this plan, because if a patient that cannot read at all is simply handed a document that says this is how you are compliant with your pain management, they will never be able to comprehend it. Yes, the verbal review is very important, but providing literacy level appropriate documentation for patients could also make a difference. That is what this project sought to see if it worked. For this scholarly project, the theoretical framework of Rogers' diffusion of innovations was employed. Although this is not specifically designed for healthcare, this framework fits studies on pain management and health literacy due to its structure. Pain, again, is one of the primary reasons that people seek healthcare, and discussions around literacy-related compliance are few and far between. Rogers proposes that changes happen through the innovation of ideas that are not necessarily new time-wise, but thought-wise, and are implemented through the diffusion of these ideas. The concepts that Rogers identified were expounded upon by White are knowledge, persuasion, decision, implementation, and confirmation. Rogers also divided persons involved in these diffusions of innovations into groups related to the adoption of the innovation. They can be innovators, or those who discover the ideas, early adopters, or those who will take the risk of trying something new, early majority, or those who accept the views after the earliest, making them a majority, late majority, or those who are later than most with the adoption of the innovations, and laggers, those who are last to adopt what has become at this point a standard of care. This framework fits the pain management setting specifically because, as a practice, this is a new and emerging field. There is much to be learned, and treating patients evolves as the understanding of what manages pain evolves. For the project of looking at compliance with recommended pain management standards related to patient literacy about pain management, this framework sets a clear example of how the adoption of these innovations may play out, and it is up to the innovators to inspire the followers to make the changes in the best interest of the patient. A quantitative explorative design through a retrospective chart review was utilized for this project. Participants were not engaged, and no patient information was abstracted from the electronic medical records. EMRs, or electronic medical records, from the clinic were utilized for data collection. The researcher recorded the minimum necessary data to accomplish goals for this project on the data collection sheet. All potential patient identifiers were removed and not collected for this project. A step-by-step outline of the project's protocol was Step 1, clinic participants were not engaged and no patient identifiers were abstracted for this project, which again was a retrospective chart review. Step 2, after IRB approval was obtained from Maryville University, the data collection process began. The clinic manager requested a random list of patients from the EMR team who generated the report for patients seen for pain management during the time frame of June 19, 2023 through August 18, 2023. This researcher had access to those charts through the course of the study, but a written list was stored on a password-protected computer in a locked office throughout the course of the study and data collection. After the data collection, the written list was returned to the clinic manager and destroyed. The abstracted data was recorded using codes to represent ranges of chosen variables and constituted the minimum necessary data to accomplish the goals of the project. Step 3. The researcher reviewed each EMR provided on the written list to determine if inclusion criteria presented in the IRB proposal had been met. After a 4-week implementation period, a retrospective chart review began, including the pre-implementation timeframe of June 18, 2023 through July 14, 2023, and the post-implementation timeframe of July 17, 2023 through August 18, 2023 for comparison data. Step 4. Each EMR used in the project was assigned a number on a data collection sheet. Step 5. The minimum necessary data was collected on a data collection sheet. No patient identifiers were included in the data collection process. Step 6. The data collection process stopped when the researcher had reviewed the anticipated 77 EMRs, both pre and post, for 154 charts total. Step 7. Once the data collection stopped, the written list of EMRs received from the clinic manager was destroyed. To discuss the inclusion criteria and be chosen for the chart review, the patients must be between 18 and 20 years of age, documented to have been seen during the specified time frame of June 19, 2023 through August 18, 2023. The EMR had documentation of a literacy level appropriate copy of the pain management contract being provided through the after visit summary for the post-implementation timeframe, and the EMR had documentation of the verbal review with the teach-back method of the pain management contract. Exclusion criteria was if they were younger than 18 or older than 80, they were not considered for this project. If they did not have a current pain management contract, or if the EMR did not support documentation of verbal review of the pain management contract. We'll now look at the data collected. Information needed for the project was extracted from de-identified patient data from the electronic medical record on a data collection sheet. The data collection sheet provided information for patients seen between June 19, 2023 and August 18, 2023 for pain management purposes. Nominal data was collected and analyzed as follows. There had to be documentation of verbal review of the pain management agreement noted, documentation of a revised pain management contract given to the patient, whether or not they were retained by the practice, reason for the dismissal if not retained by the practice, and whether or not that was an inconsistent drug screen, an incorrect pill count, or a combination of both of those. A total of 154 patient records were evaluated for inclusion and exclusion criteria, 77 pre-intervention and 77 post-intervention. The results were as followed. Pre-intervention and post-intervention, each patient did receive a copy of the pain management contract. Pre-intervention, this was still written at a college reading level, while post-intervention it was given at a 6th grade reading level. Pre-intervention, 3 patients of the 77 were dismissed for noncompliance, and none were dismissed after the intervention. Using a Z-score analysis, the results indicate that a significant difference in one direction can be seen in discharge rates pre- and post-intervention utilizing a health-literate appropriate contract with a verbal component utilizing the teach-back method. The Z-value here was negative 1.9600 with a confidence level of 96%. What do these results show? These results show that there was a significant, to a statistical level, reduction in the amount of dismissals from the pain management process program after the introduction of the intervention. What could this mean? There really could be benefits to at least including patient literacy levels in patient communications and treatment plans. This could be very useful in future practices because ChatGPT was used where the current contract, which was written at a college reading level, was uploaded and reduced to a 6th grade reading level. This could also be done with other languages and can be used for any patient documentation. However, as we will talk about in just a moment, the introduction of literacy level appropriate documentation for patients was not the only intervention that was introduced during the time period of this project. With any project, there are always facilitators. The faculty and staff of Maryville University and the faculty and staff of the clinic where the project was performed were incredibly valuable resources for the entire process. There were no barriers identified through the course of this study. However, there were other interventions that could have skewed the results that were not measured. It's difficult to say which intervention made the biggest difference because at the same time as the literacy level appropriate documentation was introduced to the practice, there was also the introduction of more frequent in-person monitoring by the supervising physician. This included anyone with a pill count that was not what it should be was offered, instead of dismissal, more frequent monitoring depending on the level of severity. This could have been once a week, once a month, for a time period of 6 months to as long as they're in the practice. And this could have made just as big or a bigger impact, and further research is needed to determine what would be the most appropriate intervention to help improve patient compliance. Research supports the use of literacy level appropriate chronic opioid pain management contract guides to reduce dismissals related to noncompliance in pain management practices. By engaging patients with contract guides that are written at a nationally accepted level and incorporating a verbal review utilizing the teach-back method, dismissals were reduced by a statistically significant amount. It is important to note that one of the issues affecting this study was increased patient monitoring with face-to-face visits much more often. This intervention can be sustained with little effort and adapted to other practices without great cost or effort by utilizing ChatGPT for other languages and other patient documents. Further research could determine if the statistical significance and difference for both interventions. These are my references. Thank you so much for listening to my presentation.